the next session on ECMO management, can I please invite the chairpersons, Dr. Sunil Kumar Bhubani, ex-president of ECMO Society of India, and Dr. Sapna Verma, clinical lead, cardiac anesthesia and CTICU from MGM Healthcare.
Good afternoon, everyone. Welcome back to the next session. Dr. Carlos Mestris is the next speaker. He will be talking on hemofiltration and use in extracorporeal circulation. Dr. Carlos is senior consultant in Department of Cardiovascular Surgery at University Hospital Zurich. Over to you, Dr. Carlos.
Thank you very much. Can you hear me well? Yep. Can you hear me well?
We can hear, but
let me share my screen with you. First of all, thank you very much for the invitation to the ECMO Society of India. Thanks for the privilege. And let's have a look at what we know today about the combination of ECMO as a strategy and hemoabsorption in all extracorporeal circuits according to our experience. I'd like to thank Dr. Rao and Dr. Balakrishnan for the invitation to join you today. Now that systemic inflammation, it's well known that impacts on cardiac surgery outcomes. I have to say that we are collecting knowledge now, I think, in this field, not on ECMO precisely, because it's been there for about 40 years, but collecting information on other alternative strategies to handle that in cardiac surgery. This is the outline for today, and we are dealing with inflammation. Everybody knows that actually this is a non-specific response against all the aggressions that we get from the environment, and actually this is the response of the body to fight against all external aggressions. That was described by Virchow almost 200 years ago in Germany, and the actual facts that we know and that we have discussed previously in these sessions are hyperemia edema, activation of endothelial cells, specifically polymorphonuclears, and diapedesis, which is what we know today as inflammation. In cardiac surgery, we do that almost every day because we traumatize tissues, we disrupt the endothelium, there is blood exposed to artificial surfaces. This is well known for years. And with this response gets unregulated, we call it the cytokine storm, which is a very accepted term today. And it's mostly accepted to be when the levels of interleukin-6 they get over 200 picograms per milliliter. And then the patients may develop SIRS, which is a systemic response. Historically, we know that what we do today is an old thing. That was the Harlan machine, and all that comes later was invented late in the 19th century by Max von Frey and Max Gruben in the University of Zurich. And this is exactly what was published in the first reference. And it looks very similar of what we use today in terms of complexity of tubbing and all the subjects that we need for any extracorporeal circuit. The main goal, of course, of adsorption is to remove cytokines. This is probably what we agree today in the beginning of our experience and our knowledge. And cytokines, they are a very complex world. We know that. I think this is a very, the one I highlighted here is a very interesting review on the topic of cytokines, published just a few years ago in the American Journal of Nephrology. And what we have seen over time in terms of how in cardiac surgery specifically the cytokine, the inflammation impacts goes through a number of studies. This was published almost a quarter century ago, where our colleagues in Brussels, they showed that it is actually the myocardium, the main source of release of anti-inflammatory cytokines. So I think that that was an important study. And then again, we know that this is the major source of tumor necrosis factor alpha and interleukin 6. 6 after reperfusion of ischemic myocardium. There were a number of models in coronary bypass, heart transplantation, and the lessons that we learned, that was also published by the same team a short while later, is that all anti-cytokine strategies, including hemofiltration, coating of circuits, interventions from the pharmacological point of view, they may be considered to reduce morbidity after surgery with cardiopulmonary bypass, including steroid administrations. But I think after more than a quarter century or more, 30 years of discussions, we know that there have been developments in anti-inflammatory therapeutics. This is why at the University of Zurich we use at the moment hemoadsorption. The only cartridge available at the moment is Cytosorb, and we use it in extracorporeal circulation, in extracorporeal life support, and also in addition to hemofiltration in specific patients. These are our indications for hemoadsorption at the moment. The most important are highlighted here with arrows. Infective endocarditis, implantation of CIS devices, specifically when there is a long operation expected, that for us is something like a couple of hours cross-clamp time. Type A aortic dissection, specifically because of the massive inflammatory release when we have a patient with dissection, considering the thrombus in the false lumen. And also we have tried that in surgery for pulmonary hypertension. This is the profile at our unit at the moment, which is stabilizing the number of ECMO implantations between 120 and 150 in the past 5 years, in a unit which handles something like 20 to 25 assist devices and about 35 heart and lung transplantations per year. And the experience with the absorber is at the moment more than 700 cartridges used in the past few years. This is the profile of patients or applications for us. You have seen that out of these probably more than 700 cases so far, 68 are used during cardiac surgery in extracorporeal circulation. We have used or we use it almost routinely in ECMO support in about 20% of the patients, and 11% of the patients this is used in addition to hemofiltration for whichever reason that causes the requirement for renal replacement therapy. These are the adsorber configurations in different extracorporeal circuits. This is the one for cardiopulmonary bypass. You see that this is placed, as you could see, after the roll pump, and this is how the pre-bypass priming is done. Of course, using that during surgery has advantages and disadvantages. Of course, the flow is controllable. We have no influence of arterial flow. Air intake is not a danger. However, in terms of weaning, it requires attention because this is an additional device in an otherwise complex circuit, as you know very well. We have used, of course, like probably many people today, in hemoperfusion. This is a typical scheme, and there's quite a bit of experience in all types of hemoperfusion procedures in the past 25 years. But this is the way in which we use it now after the roll pump, before the final destination of the hemoperfusion be, for instance, kind of lavage or whatever you want to use it. The typical ECMO integration for us at the moment for extracorporeal membrane oxygenation, you could see here. This is a very simple kind of usage. Our indications for the combination of ECMO and absorption therapy are clear. Post-extracorporeal circulation is one of the most frequent at the moment. We have supported patients for up to 48 hours after surgery with ECMO and absorption. When there is severe sepsis, meaning that the patient has developed multiple organ failure, and when there is severe vasoplegia requiring high dose of catecholamines. These are the recommended options for circuitry and tubing at the moment in our place, and this is how the you could see how in this diagram the whole thing goes when we use absorption an ECMO, which is definitely a simple one and that can be used without much harm. At the moment, we have reported no complications in more than 700 procedures directly related to the implantation or just the mobilization of the cartridge. This is at the end how it looks in our ECMO circuit, probably like the one you use it anywhere in India. And the connection to ECMO is pretty simple. And there are, of course, chances after 24 hours or even after 48 hours to modify the circuit or just replace the used cartridge. And again, I think that this is for an experienced perfusionist. This is definitely a simple, straightforward procedure that, at least in our hands so far, has not led to any acute type of mechanical complication derived from the use of the cartridge. In terms of renal replacement therapy, as you could see, more than 11% of our patients are treated routinely with hemoadsorption in cooperation or in combination with renal replacement therapy. There are a couple of options that have been tried at the moment in clinical settings, and we use normally the prayer filter configuration in your left-hand side. Why I say that? As you know, this is why the ECMO Society of India is meeting today. It is increasing worldwide. This is an accepted form of therapy after 4 years. These are data until 2017 regarding the ECMO usage. According to the EuroELSA statistics last year that were delivered at the end of the first year of the pandemic, this has doubled. And that means that this is a significant proportion of patients that are being treated, and it is very clear that usage will increase. This is our program. As I said, in the past 7 years, our has increased, and as I said, the number of ECMO implantations at the moment at our department has been stabilized between 113 to 150. Of course, COVID-19 impacted significantly last year. We have something like close to 50 implants for COVID patients at our department. And the other important thing is that when you see what happened in the past 15 years, considering the philosophy of ECMO, we have been able to decrease our mortality. So meaning at the moment mortality is between 34 to 35%. That means a survival rate of 70%, which is the opposite of what happens 15 years ago. And as you could see, in 2016, we implemented the use of absorption, which is probably another reason why slowly the results they are improving. And what I can definitely say is that we need to understand that the regulations in every country are different. I think the situations are different. The previous talk by Dr. Madan Kumar was self-explanatory, and I think also the discussion before at the end of the last session was also very clear. There are different types of practice, there are different problems, there is manpower issues in many places, and at the moment, what I can say that at least COVID-19 patients are the most important indication in terms of regulatory issue in the United States and Canada. Of course, off-label is the choice and responsibility of the treating physician, but in Europe, generally speaking, this has been accepted under certain circumstances by the European Union regulatory agencies. What we know today is clear. We have collected a bit of information, not so much at the moment, despite this is a new concomitant therapy. ECMO and cytokine absorption has been treated patients with Staph aureus pneumonia, with different types of post-cariotomy shocks. Preventive approach has been used in many patients. Safety is not an issue. Adding the artificial surfaces has no effect on system immune cell, and our main reflections are that patients with an exaggerated inflammatory response need to be identified. The relatively healthy patients do not seem to be in need of preventive approach, and when we go through different settings like transplantation, like patients with endocarditis before and after the operation, like in this setting, we see more or less the same results across the spectrum of experiences worldwide in terms of systemic resistances and the decrease in vasopressor therapy, and with absorption therapy having an impact in early mortality in severe patients. This is how it looks, the cartridge after the operation. And at the moment, we are collecting information through different trials. I think the recreating cardiac surgery is an important one, which is still ongoing in a complex design with primary and secondary objectives that are very clearly identified. But of course, trying to reduce the incidence of sepsis, control the inflammatory response, and improve hemodynamics. Drug removal has been part of the business. It is a part of the business today. This is an example of us. This is a patient coming with aortic dissection on rivaroxaban with stable hemodynamics, no pericardial effusion, with lift mouth perfusion. We use before surgery stenting, and we sterilize the patient with hemofiltration and absorption. And this is the rivaroxaban curve that after just 8 hours improve in a way that we could safely run the operation without major bleeding issues. And we published that a few months ago in the Indian Neurothoracic and Cardiovascular Surgery. So at the moment, this is why I say we are just accumulating experience and just heading to the final part of this presentation. So far, we have 371 publications related to CytoSorb as of today, and very little also on hemoabsorption, globally speaking, in terms of cardiac surgery. But last but not least, I think that it is important to remember the CTC registry that came with the COVID-19 infection about a year ago, multi-center registry in the US. This is a multi-center registry collecting demographics and characteristics of patients on ECMO treated with or without CytoSorb under the exemption approval in different centers in the United States. I think the most important was to check that the mortality dramatically improved in the ICU up to 90 days in patients with or without absorption therapy. This is more or less the diagram on follow-up days until 90 days. And probably, again, the most important is that absorption plus ECMO survival at 90 days was 73% compared to 50% with ECMO alone, and that was statistically significant. I think this is probably too much for the moment. I have to say, of course, that our level of knowledge is still not too important because we need to collect more data from trials, especially controlled trials whenever possible. However, having a look at that, which is a very huge topic, I must conclude that, first of all, at the moment, available studies are still small-sized and retrospective, including a couple from India. There are some benefits, of course, in endocarditis. This is an easy-to-use hardware. We have recorded no cartridge-related complications, and what is common across the publications is that there is a reduction of pharmacological support in these critically ill patients intraoperatively and postoperative when the therapy is continued. We have different tools to address all needs, and probably with this limited level of knowledge we have at the moment, in patients with a high level of systemic inflammation, CytoSorb therapy may enhance intra and postoperative hemodynamic stability in patients with or without ECMO, and there is a reduction of postoperative and intratherapy requirements, especially in those patients on ECMO, and it can be used as a concomitant therapy in every single type of extracorporeal circuit in cardiac surgery and out of cardiac surgery at the moment. And I'd like to thank our perfusion section for the phenomenal work done for us in the past 7 years. And thank you very much for your attention, and I am at your disposal should any question arises. Thank you very much.
As Dr. Carlos is speaking from Sweden, I would like to ask if there are any questions so that he can answer. Any questions? If no, yeah, please. Dr. Vinod Singh.
Yeah, it was very nice presentation, Dr. Carlos. One
Thank you very
question
much.
is if you are starting for the septic shock patient, what are the objective criteria when you choose to start a cytosorb in such patients? Whether it
Yeah,
is,
this is.
yeah.
No, thank you very much. I tell you, this is still something that needs further discussion. The reason being, as I said, that this is supposed to be a relatively novel therapy. We have been using that for 5-6 years. I think the problem at the moment is that the community needs to agree on specific timings. We know that every time we have a new therapy, it happens. I remember when I was young that ECMO therapy was recommended in patients that were moribund at that time. And we are becoming more and more aggressive and proactive in these patients. The discussion before this session, which was excellent to me, was talking about ethical issues and kind of timing or when the patient should be implanted or if the ECMO should be implanted in patient intubated or not. I agree. In this case, we have started ECMOs, of course, with the extubated patients, but of course the intubation patients are those under, of course, previous ventilation or CPR and so on. With the initiation of absorption in septic shock or circulatory derangement, I think that has to be definitely evaluated by the treating physician. But of course, I think the basic definition of shock in terms of hypotension, distal perfusion, hemodynamic parameters should be enough to take an immediate decision. I think probably we are going in a direction in which we are probably going to be more proactive as soon as we know a bit better and understand better how this kind of therapy works. My feeling, and this is our experience in our place, is that we do not hesitate to place the patient on hemoabsorption, one minimum certain criteria, and especially the timing criteria as soon as possible when we have definite criteria and not waiting to see if the patient improves. So this is something that we are now learning, but my conduct could be just define what shock is, circulatory septic, and then immediately decide to use this sort of therapy. This is what we have learned from other therapies before, not only with this one.
One more thing, sir.
Please.
Yeah, because most of the septic shock patients, once you start VA ECMO, so their cardiac output and their hemodynamic and the shocks are bound to stabilize. So once our VA put the patient on VA ECMO and the hemodynamic parameters have stabilized putting on the VA ECMO, then where is the place for the cytosorb in such situation? Or are there any specific indications you decide, okay, this patient, even the hemodynamic is stabilized, we have to put the patient on cytosorb, or there are different subset of patients who you think that potentially are going to improve even the hemodynamic has been stabilized?
Yeah.
That's the question.
No, thank you. No, sorry. I mean, this is very, very interesting because it enhances our exchange. I have discussed about patients which are basically cardiac surgical patients. And of course, we know that in the ICU, not all patients are patients who had extracorporeal circulation. And most of our patients that you could see, in 70% of them, they were patients that we operate on and we use the absorption in the operating room during cardiopulmonary pass, and then after weaning off, we disconnect the absorption. In about 10% of the patients, we have continued the therapy for 24 up to 48 hours. And the indications for most of them are post-operatively. It is clear from the scanty literature, this is why I say that we are now learning that patients with a septic component like endocarditis patients, especially, or patients who came with postoperative septic shock, these patients, they have an increased inflammatory component, and in some of those patients, especially Staphylococcus aureus patients, there is release of specific toxins that can be also removed. And the typical case of Staphylococcus aureus sepsis with Panton Valentine leukocidine, which is relatively frequent, this is one of the examples that could illustrate when we may use that. Again, if you remember part of the presentation, we have 4 or 5 indications that for us are, I'm not saying mandatory, but they are advisable because the inflammatory component is very important. And again, in the patients that come to us in a situation that they require ECMO support, which are frequently seen in our hospital, is something like 1 patient every 2 or 3 days. Most of these patients, they have hemodynamic derangement, and a small proportion of them, they are actually septic shocks. So the discussion is there. But I think that patients with combined hemodynamic and septic shock, they should be good candidates as long as you indicate that as early as possible. That's according to the regular criteria that the community accepts. I'm not sure if I'm responding to your question, but probably the type of patients that they are purely ICU patients, they are not the same like patients who are cardiac surgical patients that require other types of therapy, or just the patients, the group of patients with ECMO support.
Thank you. Thank you very much.
Yeah. Do you monitor the cytokine levels before and after using the filter? If so, what's your target values, or do you do anything for that?
Well, I think in not every place they can do that. We do that as you do. But I think the decision about withholding the therapy is not only based on the level of cytokines. Of course, if we accept that a serious patient with serious inflammatory response has an interleukin-6 level of about 200 picograms of higher, then the target should be the lowest as possible. But normally, patient who has an improvement in the cytokines and the biomarkers after therapy, for instance, after 24 hours, normally is the patient who gets better in terms of pharmacological requirements, in terms of course, the epinephrine or adrenaline, and this is a combination of factors. So when we see a patient that improves, it's not only because the interleukin levels of the tumor necrosis alpha levels they are under control, is because the whole patient generally speaking improves. And probably the easiest way to see that is not only by monitoring the interleukin-6 levels, but also seeing how in something between 8 and 24 hours after the initiation of the therapy, the requirements for norepinephrine, epinephrine, or vasopressin go. You know that most of these patients, they're going to be very high in 0.1 vasopressin or even 0.3 adrenaline. So this is something that we can easily monitor. But I think if we, again, take as the level of interleukin-6 level of 200 as a very high, very severe, we will see an improvement of these serum levels in combination, in concordance with the requirements of vasopressors as well.
Thank you, Dr. Carlos. In the interest of time, we'll move on with the
I appreciate
talk. Thank you.
Thank you very much. I appreciate the invitation. Thank you very much. Good evening, everybody.